Hello, everyone. My name is Dr. Omran Bishbish, and today I'm going to be presenting a lecture on the current advancement in implant dentistry. Before I start, I would like to extend my gratitude and my appreciation to Dr. Mazen Doumani for creating this platform where we can all share our experience and knowledge and learn from each other. I know he's been doing that for the past couple of years, and it takes a long effort from him to put everything together. So thank you very much, Dr. Mazen, for that. And thanks for your invitation as well. Again, I'm going to just give you a quick background of myself. Originally, I'm from Syria. I finished my dental education in 2008 from Damascus University. After that, I joined an oral maxillofacial residency program in Damascus Hospital, where I did 4 years of training. After that, I moved to the United States in 2013. And I joined the International Dentist Program in Loma Linda University. And I graduated in 2016. I practiced for 3 years outside, and then I started a residency in periodontics and implant surgery in Loma Linda University again in 2019. And now I'm finishing my second year. I'm going to start my third year of training, and hopefully I'm going to graduate next year. So without further ado, let's jump into the lecture. We are going to talk about history briefly, and then we're going to talk about the guided surgery and digital flow work for single implant placement and implant supported fixed partial denture or implant bridges, and also for implant supported complete denture. And we're going to talk about dynamic navigation. And after that, we're going to talk briefly about the implant soft tissue phenotype, or tissue phenotype as general. And also we're going to talk a little bit about hard tissue grafting. So before we know the implant, and before it was presented by Dr. Brainmark, there was multiple attempts throughout the years, starting early 1900s, to do screws from different type of metals, sometimes radioplatinum, sometimes chromium cobalt alloy, and sometimes from stainless steel, and implant these screws inside the jawbone to replace missing teeth. And after that, as we went to the 40s and 50s, there was the development of the superior steel implants and also the blade implants in the 1960s. And most of these implants failed because of either biologic or mechanical issues. So there was no osseointegration, or there was some mechanical issue with the design also with these implants. And this is an example of the blade implants on the right here, and also on the superior steel implant. And in this example, they're trying to replace the maxillary edentulosum using a superior steel implants. I've seen one patient in Loma Linda University who has such a type of implant supported prosthesis, and it's been there for I would say for 40 years, but this is the exception. It's not the norm. The norm is that these implants fail shortly after placement, again, because either a biologic or mechanical issues. So after that, Dr. Brainmark came up, and he was working and studying the bone healing in the rabbits, and he implanted some titanium chambers in the rabbit femurs in order to monitor how the blood grow and how the bone heals. And he noticed that these chambers, or the titanium chambers, became very, very integrated with bone and very hard to remove. And he applied this concept to dental implants. Starting in 1965, he started treating patients, and he presented the two-stage threaded implant system in 1978, as we know it as the Brenmark system, which developed later as a Nobel Biocare. And in the 1990s, he presented or introduced the zygomatic dental implants, which anchor the implants in the zygoma bone. And this helps individuals who have suffered significant bone loss or patients who had tumors or big resections that removed their jaw. So basically, Dr. Brenmark is the one who presented the dental implants as we know. And mainly, this is photos are taken from his original article. This is the titanium chamber in the femur of the rabbit, how it looks like. And this is how they did how they used these implants to restore full arch cases. Mainly, they started with the mandible, and then they started rehabbing also the maxilla. And if we take a look at this right now, it looks like the all-on-5 or all-on-6 concepts that currently went back to the surface. Mainly, when they did their implant placement, they followed the bone, so it was like a surgically oriented or bone-oriented implant placement. And over the years, there become a need to classify the success of these implants. As more and more people started doing these implants, and they started using them to do single teeth or fixed partial dentures, or what they call them bridges, there become a need to classify what is a successful implant, how does it look like. And Dr. Albertson proposed these criteria that the implant has to be immobile when tested individually, so no mobility of the implant. There should be no radiolucency around the implant, and the vertical bone loss around the crystal bone loss around the implant shoulder should not exceed more than 0.2 millimeters annually following the first year of implant placement. At that time, it was accepted generally to have some crystal bone remodeling after the implant placement, and some people talked about 1 millimeter, some people talked about 1.5 millimeter of crystal bone loss, and this was considered a normal process. But following this first year of remodeling, there should not be more than 0.2 millimeter of bone loss every year. Other criteria is there should be no bone and no pain or no symptoms or no nerve damage or violation to vital structures. And taking into these criteria into consideration, they found that 80% of these implants are considered successful over 5 years observation, and 80% of them are considered successful over 10 years period observation. These criteria have been adjusted a couple of years after that by Dr. Smith, and they added one important criteria, which is the implant design or placement or position does not preclude the placement of a crown or a prosthesis, which and with an appearance that is satisfactory to the patient and the dentist. So here they started thinking more about the prosthesis itself, about the crown, the bridge, how does it look like, aesthetically and functionally, and not only about osseointegration. And basically, we want to avoid situations like this where the implants are integrated, they're not mobile, there's no bone loss, but prosthetically, they're not very pleasing, or aesthetically, or functionally. And these photos are taken from the internet. This is an actual patient that I have. We can see the amount of cantilever because the implant is placed distally, too much distally, and this cantilever created a problem with the forces on the crown, and we kept getting screw loosening and the crown kept getting loose. Also, we had a problem with the hygiene and cleaning under such a cantilever here. So we want to avoid these situations, and that's how the implant dentistry shifted from a surgically driven approach to a prosthetically driven approach. And we started thinking about designing the implant restoration first and then work backwards. Usually when we do design the implant surgery or the implant prosthesis, we have to there is a lot of factors that we need to think about. Some of them are the interarch space, the intra-arch space, mesial-distally, how much space do we have between the adjacent teeth, arch curvature, jaw relationship, facial support, smile line, bone quality, phonetics, tongue position, gingival level, gingival phenotype, etc., etc. So there is a lot of factors to be considered, and it depends on the type of restoration that you're planning, whether it's a single implant or it's a implant supported fixed partial denture, or it's a full complete implant supported complete denture. So this concept of prosthetically driven implant placement have led us to the need of a guided implant surgery. So we need to have guides that guide our implant placement where we need it to be. And this chart summarizes what type of implant surgery do we have. We have freehand approach, which a lot of doctors and dentists, they're still using it, especially the more experienced ones. And they have no problem with that most of the time, but sometimes it becomes tricky, and it's always beneficial to have some type of guidance where you want to place your implants. The other type of implant surgery we have is the static navigation or static guidance. So what is that? It's basically we have a guide, we place it in the mouth, and it will guide our implant placement. But this guide is stable, it's static, it doesn't move, it doesn't change. So once you design it, there is no way to adjust it afterwards. And this have multiple kinds, and it might be tooth supported, or bone supported, or mucosa supported. It can be open or closed according to the how you see your drill through it, or it can be fully guided. You can use all your drills through the same guide, or it can be half guided, so you can use only your pilot drill just to mark where your implant is going to be, and then you go freehand from there. So there is different types of it, but basically all of them, they share the same concept of fabricating a guide that is static. once it's designed, you cannot change it. And the other type of implant navigation surgery or implant surgery that came to the surface lately, it's called the dynamic navigation. And we're going to talk about it later as well. It gives you an instant feedback, and it's not static navigation. It's a dynamic. It's more interactive. So how did we use to fabricate the guides? Basically, we used to take impressions. We do mounted casts like this, and then we do diagnostic wax up, or we have denture teeth. We glue them to the cast to just kind of mimic how our implant, our restoration or crowns or bridges are going to look like in the future. Once we're happy with the position, we fabricate a vacuum clear splint. It's like some type of a night guard. And then we remove the denture teeth from this splint. And we have this clear splint with the hollow in it here, in the area where we will design our future crowns. After that, we fill this space with a radio-opaque self-curing methyl methacrylate, and we trim the edges, and we end up with a situation like this or like this. And then after that, we locate where our exit point for the screw hole is going to be, and it's usually in the central fossa or the cingulum of the tooth. And we're always shooting for a screw-retained prosthesis, whether it's a singular crown or whether it's a partial denture or a complete denture. For obvious reasons, we try to stay away from the cemented crowns or cemented prostheses, because the screw-retained offer two major advantages, which are retrievability. You can retrieve it easily, and also there is no excess cement that needs to be cleaned, and that if it wasn't cleaned enough, it might compromise the implant health in the long run. So after we locate where we want our exit hole to be, we use just a drill, 2mm twist drill, or any disposable drill that we have, to cut the hole through the acrylic unit all the way until you touch your cast like this. So we have two holes. And then you place it in the patient mouth, and you take a CBCT scan, which is now a standard of care for any implant procedure that you are planning to do. And that's going to serve as a radiographic guide. So you will analyze where are your crowns, where are these holes are going to be located, because the holes that you created are going to be radiolucent. And you can plan or you can analyze how much bone you have, and what's the anatomic structures that are near to your implant or future implant position are, and you can plan the case accordingly. But and you can use this guide as a surgical guide later. The same guide, you put it in the patient mouth during the surgery, and you start your drilling, initial drilling or a pilot drilling through these holes. What is the downside of this? The problem is that you cannot plan the exact position of the implant. So this system or this method is not interactive. What only you have is a tool to analyze. This is just to analyze how much bone do you have, and where is the implant is going to be positioned as a general look, but not detailed. And the other problem is that it involves a lot of lab procedures as well. But it's a reliable method to analyze how much bone you have and to guide you at least mesial distal location of these implants. Where are they going to be? So it's better than a freehand for sure. With the advancement of the intraoral scanners and the softwares and the CPCT scans, we have the privilege now to work with the digitally guided implant placement. We use basically, there is a lot of softwares out there. DTX from Nobel, we have 3Shape, we have Blue Sky, we have CareStream, and we have In Vivo from Anatomage, and among others. There's a lot of softwares available as well. They share almost the same components, all of them, and basically this is called a digitally guided implant placement, where you can upload your scan, intraoral scan and CT scan, and plan your implant accordingly. So let's take a look how it's going to look like using one of these systems. So what do we need? We need an intraoral scan, and I know that the scanners are expensive, and the majority of the dentists, they don't have the luxury of owning a scanner in their offices. So what we can do is we can take a regular impression, an alginate impression, pour it, and then send it to a lab who have a scanner, and the lab can scan this cast for you. The other thing that you need is a CT scan. Again, it's a standard of care now for implant treatment planning. You need a software, and you need a 3D printer, or again, you don't have to have it in your office. You can just have a lab that have a 3D printer. And most of the labs right now, they do have 3D printers, and they do have intraoral, or they do have scanners in general that can enable them to scan your cast. So how does the workflow looks like for single implants and for complete denture cases? Let's look at it. So using here, I'm using a 3Shape software. First, we start by telling the system what type of restoration are we doing and what type of implant are we doing and the tooth number. And then we upload our intraoral scan, as you can see here. And then we upload our CT scan, as you can see here. The next step is to merge these two scans together. So either the system automatically recognizes the scans and merge them together. If the scans are not very clear, sometimes the system is not able to recognize it automatically, and you have to do it manually, where you mark 3 marks on your scan. For example, the first molar, the central incisor, and the first molar on the other side. So you mark those areas on your scan, and you mark them on your CT scan as well. And the system then recognizes these areas and merge the scans together. And what you ended up is like this, where this yellow line is your intraoral scan, and then it sits perfectly on the teeth as they appear on the CT scan. So from here, the system moves you to the next step, which is designing your prosthesis, which is a single crown or fixed partial denture. So you design your crown how you like it, with the proper occlusion and mesial distal position and facial lingual position as well. Once you're satisfied with this, you will be able to design your implant. And again, you'll design an implant so you can have a your access hole in the central fossa of your crown, and mesodistally and facial-lingually has to be within the bone envelope. At least you have to have 2 millimeters of bone surrounding it. If you don't have it, you have to plan for bone grafting and other procedures. So I'm not going to go over details over implant planning and what the requirement of implant planning individually, as we all know about it, but you can play basically with the implant position until you are satisfied with it. So you can sometimes compromise some things to gain other things. For example, you can tilt your implant a little bit more lingually, so you will have more thickness of your bone here on the buccal at the implant platform, or vice versa. So it's a nice interactive tool in the software, and it gives you a lot of liberty to move your implant and play with it until you're satisfied. Once you finish designing the implant and the crown, you move to the next step, which is designing your guide. Again, it's simple and easy, and basically the system gives you all the guidance to move from one step to another. So it's fairly easy to use, and you just draw your guide like this, and the system gives you this final product. Again, before I go to the next step here, when you design your implant, you have an option to choose the implant system that you're using, and the implant width and the implant length. So there is a whole library of implant systems already downloaded into the system. So once you design your guide like this, you move to the next step and you generate an Stl file. This Stl file, you will send it to your printer, whether it's in your office, or you can send it to your lab, and the lab can print the guide for you. And this is how the guide looks like after printing, and this is how it looks like after you trim these extra material. And this is an example of a tooth or teeth supported guide. So this guide sits on the teeth and is stabilized by the teeth cervical undercuts. And from here, you move to surgery, you place your guide, and you make sure it is stable. This here metal sleeve, you attach it to your guide, and it depends on whether you want to go fully guided or half guided. This diameter of the sleeve changes. So if you want to do only your pilot drill, you can use a different metal sleeve which has a smaller hole here. You placed it, and then with your pilot drill, you go through the hole, you drill your pilot or initial drill, and then afterwards you remove the guide and you finish freehand. The other option is to go fully guided, as I did here in this example, where we use this sleeve, and there is keys, as you can see here. This is called a key that fits into the sleeve, and this implant drill or burr fits snugly inside the sleeve, so there is very minimal room for error on your angulation. And then you just go and you do your drilling, the first drilling, the pilot drilling, and then you move until your final drilling according to your plan, which if you're doing 3.5 or 3.75 or 4.1 millimeter implant or 5 millimeter implant, it depends on the implant diameter that you're using. Once you're done with that, you can place your implant and do your suture. And as you can see, you can choose to go flapless surgery, or you can just open a flap. It depends on you, on your preference. I always use a small flap. I don't like to, the bunch technique, I don't like to remove soft tissue. And here in this example, I preserved the tissue distal to the premolar because this is an implant and I did not want to expose the implant threads. So it's basically your placement is accurate, mesial distally, facial lingually, and it's prosthetically is going to be in a good position for the future crown. This is a different example on the closed and the open guides. So as you can see, the closed guide, closed visibility, you cannot see your drill once the drill tip pass this sleeve. Here it's more of an open type of example. You can put it on the teeth and you can monitor your drill tip as it goes to the bone. Not a lot of people use this. Mainly I've seen this been in use. Some people use it, but I don't think I've seen it before. So how does it look like for bridges or implant supported fixed partial dentures? Basically the same steps. You merge the scans into the system, and then you design your bridge. As you can see here, we have one abutment and here the other abutment, and you play with the design to the mesial distally, facial lingually, to where you like it. And then you plan your implants accordingly. So it's basically the same steps. You want to make sure that your implants are parallel to each other and the excess screw hole is in the cingulum area or in the central fossa of your posterior teeth. And then you move, you do the guide, and you do the surgery. So again here, the screw access hole is going to be in the cingulum area for an anterior bridge. So this will cut down the surgery time. You can go very minimal flap, and the procedure is going to be almost flawless. So how does the process looks like for an implant supported complete denture? How do we do that? Again, we always start with a complete denture made to the best aesthetic and functional position for the patient and for you. So both of you have to be happy with the aesthetic and with the function of the denture. If your patient presents to you with a good denture, he likes the denture, the bite is good, is not collapsed, the vertical dimension is good, aesthetic is good, and the stability of the denture is good, then you can use that denture. If not, then you have to start from the beginning and fabricate a nice denture for your patient. And then you move to the next step, which is attaching this metal marks on the denture. We use this sure mark labels. It's basically metal attachment balls. You attach 3 on the buccal side and 3 on the lingual side, as shown here in the photos. And you move to the next step. The next step is you position your denture in the patient mouth, and you take a CT scan of the patient wearing the denture with the markings in the dentures. After that, you remove the denture and you take a CT scan of the denture with the marking in the same position. We have to be careful in this not to change the metal markings position. They have to stay at the same place. And also we have to change the CBCT scan settings in the machine from scanning bone to scanning denture. So after this, we end up with 2 scans. One is the CT scan for the patient with the denture in place using settings for bone. and another scan or CT scan for the denture, specifically with the different settings. And the metal markings here and here are not very recognizable in this photo, but we can easily recognize them here in this other scan. What do we go from here? We go to the next step. We upload everything in the software. Here, we're using a different software. It's called Blue Sky. And once we upload these two scans, we merge them together. How do you do that? This is the job of these metal markers. The system will recognize these metal markers on the CT scan of the patient and on the CT scan of the denture, and will merge these two scans together. And this is how we end up. Bone of the mandible, bone of the maxilla. This is the maxillary denture, and this is the mandibular denture. And this is a coronal view showing the same. This is the maxillary denture and the mandibular denture in occlusion. So you mark your nerve here, and this is how it looks like in 3D. It's like a live patient sitting in front of you with his dentures on. So from here, we move to the next step, which is planning the implant position according to the desired final restoration type. What does that mean? We have multiple options in full denture cases. We either do implant supported overdenture, or we do implant supported fixed complete denture. So it's either removable or fixed. And there is a difference between the two of them regarding the implant number, the implant position, and also the interocclusal space requirement. So for example, I'm not going to go into details into that as well, but in this example, we were planning an implant supported overdenture, which is removable. And as we can see here, this is the maxillary denture, this is the mandibular denture, this is the plane of occlusion here. And for such type of restoration, we need 9 to 10 millimeter from the implant platform to the occlusal plane. So we can position our implant according to that. So it will be surrounded by bone in a good position and a good AP spread, anterior posterior spread, and also in a good position where we have at least 9 to 10 millimeter of this space between the shoulder of the implant or the platform of the implant and the occlusal plane. What if we don't have enough space? Then we have to place our implant a little bit more apically or subcrystally, and we have to grind the extra bone away. And that's how we fabricate something called a bone reduction guide. This is how it looks like. So this is bone reduction guide. We fix it on the bone using these screws, and then we grind all this yellow area here, the extra bone, and level it to have a nice table for our implant to be placed. And same thing on the maxilla, but here I just want to show you the difference between the bone reduction guide and the implant guide on the maxilla. So once we do that, again, we're going to generate an Stl file and send it to our printer or to our lab, and the guides will be printed. And then we go to our surgery. We open the flap of the maxilla. We position our bone reduction guide and fix it to the bone. And this is an example of a bone-borne guide. So it sits in the bone, on the bone, sorry. we grind this bone and level it, and then we place our implant placement guide, and we do our implant placement. And this, again, this example I did fully guided using different sleeves, and we place our implants. And this is after suturing. And this is, you can see, buccal bone is good around our implants, and the AP spread is more than enough. Again, this is the same thing on the mandible, bone reduction guide. We trim this bone, and then we place our implant placement guide, and we place our implants according to the plan, and we suture. So this will make our surgical time less, and our also implant placement more accurate, and reduces the stress and the headache. So if we go back to this chart, we talked about the freehand placement, and we talked about the static navigation of, or using the guides, the stable guides or the static guides for the implant placement. And now we're going to talk briefly again about the dynamic navigation. So this is the dynamic navigation concept is it's using of an active tracking system that emits infrared light that is tracked by cameras. And here we can see the device. It's called the XNav device. It has a computer here with a table, a screen, and it has this arm, and there is this huge big camera on top of it. So how does it work? Basically and simply, there is tracker that is attached to the patient, and another tracker that is attached to the handpiece. And on these trackers, there is fiducial marking that looks like this. So this big camera here sends infrared lights that is reflected from here and then picked up by these cameras. So it will recognize these markings on the patient tracker and on the handpiece tracker, and it will help with the recognizing the position of your patient and the position of your handpiece and your drill relative to your patient or your patient jaw. So how does it work? Again, it's basically software. We need to have a CT scan of the patient, and we need to have intraoral scan as well. We upload them to the system, and the system is very, very user-friendly, and it's easy to use, and it will guide you to each step. Again, we merge these two scans together, and this is how we have it. And then the next step is we design our prosthesis, which in this case is going to be a crown on tooth number 3. So we can control mesial distally, buccal lingually, and in all 3 directions, how is our crown is going to look like, and the dimensions of it, and the occlusion, and etc., etc. After we're happy with the design of our restoration, we go back and or we move forward to the planning of our implant, and keeping in mind the position of our crown. So the crown here is in light blue, and this is our implant position here. We design it to have an access screw hole through the central fossa of number 3, or of the virtual crown. And we have to have at least 3 millimeter of clearance between it and the adjacent tooth, 1.5 millimeter clearance from the adjacent tooth. And in this case, we are planning to do simultaneous sinus graft procedure. And it's going to be through the crest. So we move to the hardware part of the system. We have these hardwares. This is called the X-clip, and we're going to see how we're going to use it. We have a calibration disc. We use it to calibrate our handpiece. And this is a go plate. We use it to calibrate our burrs. And there is a patient tracker and a handpiece tracker and a screwdriver and a wrench. So how does it work? We have the X-clip, which is a plastic clip that have 3 metal dots here. And in the inside, it has a material that will mold around the teeth once it's moldable. So it becomes moldable once you put it on a hot water bath. So this material changes from solid to moldable, and then you put it on the teeth and you press it around the teeth. You have to position it on the same arch where is your future implant is going to be. So if you're placing an implant on the upper or on the maxilla, you have to use one for the maxilla. If you're planning another implant for the mandible, you have to use another clip for the mandible. So after you place it on the teeth and it molds around the teeth, take the shape of the crown of the teeth, you can irrigate with cold water, and then the material is going to harden again, and then you can remove it and then attach the tracker arm to it. And there is many options of the tracker arm to angulate the tracker away from your vision, whether it's a left side, one for the right side, and one for the anterior. And then you attach the tracker arm to the patient tracker. And after that, you place the whole assembly in the patient mouth. So it looks complicated, but it's not that complicated once you get familiar with it. The other step is you attach your handpiece tracker to your handpiece and you secure it using a wrench. And this is how you have it. And then the other step, or almost the final step before the surgery, is to do your calibration. So you place all these trackers beneath or underneath the camera. And so the camera will recognize all these pieces together. And after that, you move to surgery. So the surgery is done under this camera. All these trackers should be recognized with the camera at all times. And it will give you an active guidance or an instant guidance as you do your drilling. So here, as you can see, is my future or virtual implant. And this is the orange line is my drill as I am drilling. So it's very interactive. If you need to change the plan for any reason, you can do that, and you can still see where is the tip of your implant is going to be, and your the tip of the drill is going to be, and the angulation of the drill is going to be if you're perforated through the buccal wall or through the lingual wall, or you get too close to the canal, or you get too close to the sinus, etc., etc. So it gives you the liberty of doing some adjustments during implant placement as well. So this is why it's called dynamic navigation. So the surgery is done while you are looking at the screen. So you're not looking at the patient mouth. You're actually looking at the screen, and you have to adjust your handpiece according to what you see on the screen. And this is a little bit tricky. So, and it has a very steep learning curve. We start using it on models, and we get some training on the models, and then we can use it in the patients. And it takes some time to be comfortable with this technology, but it is very helpful. Overall, it's a very nice and helpful technology. So let me share with you a quick video of how does it look like. So as you can see, all these trackers are under the camera, and I'm looking at the screen and seeing my drill as I'm advancing it through my osteotomy and until I reach the sinus floor. And with this surgery, I was using the Versa drills, which are used for osteodensification, and it's used for the crystal approach for sinus grafting. And this is a radiograph showing the burr in place and also my bone graft. And this is after implant placement and the bone graft that we did. So it's a nice and interactive technology and very neat to use. It has a learning curve, but it's very interesting. And I think the future is going to be for these type of technologies, because it's advancing every day. It's the instruments and the markings and the trackers are going to become smaller and more user-friendly, I think, in the next coming years. So this is, again, how it looks like. I'm drilling and I'm looking at the screen. I cannot look at the patient mouth, or I can look at the patient mouth, but ideally I should be looking into the screen and make sure that the position of my drill is the same as my virtual implant plan. Otherwise, I'm going to be going somewhere else. Even if I went somewhere else, or there was a change in the angulation or the depth, I will still see the tip of my implant. Where is it relative to the bone or relative to adjacent teeth? And this is the nice thing about this technology. So again, during placement, this is my drill, and I have to make sure that this drill follows this implant, which is in blue. So I have to keep looking at the screen and keep my hand very steady and follow this implant position. And this is how I place 2 implants with it in the mandible, and that's how it looks like. The nice thing about this technology, again, is that you don't need to print any guides. You don't need any printers or anything. It's all digitally done. What is the evidence? Do we have any evidence with the use of this technology? I mean, it's been, again, in the market for 5-6 years now, and there is a lot of model studies comparing it to freehand and comparing it to other type of guides, which is the static guides, and they found better results than freehand, better control than the freehand placement, and almost similar results in terms of angulation and of the implant head or the platform or the implant apex compared to the use of the guide. So it's comparable to using a static guide, but it's better than freehand for sure. And also we have some clinical studies on live patients, again, comparing it with freehand positioning or comparing it with the static guides. And again, they found a positive results that support the use of this technology. It's better and more accurate than freehand, and it's similarly accurate to the use of conventional guides, let's say. So what are the advantages? Again, the advantages is to improve the precision of implant placement compared to the freehand method. And also it provides a feedback or instant feedback during the surgery. And if you need to modify, you will have the liberty to do that. And you will monitor your drilling as it goes into the bone. And this type of luxury, you don't have it when you're doing your surgery as a freehand or when you're using a static guide. You cannot monitor the actual angulation and depth of your drill relative to the bone. The disadvantages is that it's technique sensitive. Once you get familiar with all the components and parts, it gets easier, but if we have an error in one of the steps, it will reflect on the following steps, and the whole situation becomes compromised. But the nice thing is that there is multiple safety points that is built up in the system to make sure that you are accurate in your calibration and accurate in your clip position and in your tracker position, etc., etc. Also, it has a learning curve, which is steep and very hard to learn. And the other disadvantage is the higher cost as well. So with that, we finished the talk about the guided surgery, and we're going to talk briefly on another subject now, which is called the Peri-Implant Phenotype, or the tissue phenotype around the implant. And what the phenotype means, or what we mean by that, is the morphology and the anatomy of the tissue, mainly soft tissue around the implants. So what is this implant phenotype? It has two components, a soft tissue component and an osseous component. And we will look at both, but mainly we're going to focus at the soft tissue component. So what are the three subcomponents of the soft tissue component? We have the peri-implant keratinized mucosa, and we have the mucosal thickness, and we have the supracrystal tissue height. So let's take a look at those. First is the keratinized mucosal width, which is the distance from the free gingival margin to the mucogingival junction. So this vertical distance from here to here. And this is important for the functional and aesthetic maintenance of the implant and the implant restoration. And there is increasing amount of high-level evidence that associates inadequate keratinized mucosal width with less than 2 millimeter with peri-implant mucositis. So if we don't have enough keratinized tissue around our implants, it will be more prone to peri-implant mucositis and peri-implantitis and plaque accumulation and difficulty cleaning as well. So 2 millimeter is our limit. If it's less than 2 millimeter, it's considered inadequate. And if it's more than 2 millimeter, it's considered adequate. The other component is the mucosal thickness, which is the horizontal dimension of the peri-implant soft tissue. And it's here from this area to this area, the thickness of the gingiva around your implant and your implant restoration. And this will again play a critical role in the functional and aesthetic outcome of the implant therapy, as well as the maintenance of the peri-implant health. Again, there is a mark of 2 millimeters, where less than 2 millimeters is considered thin, and more than or more than 2 millimeters is considered as thick. And it depends on the how they came up with the 2 millimeters. But most of the studies showed that less than 2 millimeter of thickness will have an effect on the visibility of the abutment or the crown around of your implant. So this will be visible. And as we can see here in this example, we have a crown, we have an implant, and the abutment is showing because the mucosa around the implant platform here, or the implant abutment, is very thin. And also we have a lack of keratinized tissue. So we have two problems. The keratinized tissue is absent. We have no keratinized tissue. And also the mucosa is very thin. And we have a high frenum pull as well, as we can see. What is the third part of the soft tissue component of the phenotype? It's called the supracrystal tissue height. So this is the vertical dimension of the soft tissue that surrounds a dental implant from the mucosal margin to the crest of the bone. So this is from the pharyngeal margin to the crest of the bone. It's from here to here. And this is composed of the sulcular epithelium, the junctional epithelium, and the supracrystal connective tissue attachment here. This is, or was used to be called, the biologic width around teeth or around dental implants. Now we call it the supracrystal connective tissue attachment. So this is an important factor again of the implant soft tissue phenotype, and it plays a critical role in marginal bone loss patterns. So if we don't have enough height of this tissue, so if the distance from here to here is not enough, then the bone will remodel and resorb until it creates an enough distance where it's away from the sulcus and away from the bacterial irritation and all away from the oral environment, or it's away from the attachment of the implant to the abutment. So most of the studies again showed that 3 millimeter is the limit. So if you have 3 or more, you're adequate, or if you don't have, or if you have less than 3 millimeter, it's considered inadequate in the supracrystal tissue height. This is an important thing to think about when you place your implant. So now majority of people tend to place their implants subcrystally more, so they will have more control of the supracrystal tissue height. And the more deep, and until a certain limit, of course, the deeper this 3 to 4 millimeter will give you a better results to control the bone remodeling, and also to control a nice emergence profile for your restoration. So this is a couple of examples from the internet showing improper soft tissue phenotype. As you can see here, there is lack of keratinized tissue and also the height of the tissue is not good. So we have bone loss that happened, and the mucosa as well is thin. Here also we have a combination of factors where there was lack of bone and the implants were placed too facially, and the mucosa is thin, and there is almost no keratinized tissue as well. And we want to avoid these situations as much as we can. So what is the other component of the peri-implant phenotype or tissue phenotype? It's the bone. And the bone thickness is it's the horizontal dimension of the osseous tissue that supports an osseointegrated implants, and this is the bone thickness from the implant surface to the outer surface of the bone. And it's very important for peri-implant tissue stability, aesthetic, and health. So the bone also affects the soft tissue as well and dictates how the soft tissue looks like as well. So the relationship between the bone and soft tissue is complicated and it's interactive. It goes both ways. So what is considered thin is less than 2 millimeters. What's considered thick or appropriate is more than 2 millimeters. I would say 15 years ago, these numbers were 1 millimeter. So we used to think that 1 millimeter of bone surrounding the implants is enough. Now the numbers changed to 2 millimeters. There is some people pushing the limit, pushing these numbers a little bit more to 2.5 or 3 millimeters as well. So what happened with the soft tissue when the tooth is removed? There is loss of bone and loss of tissue is expected after the tooth is extracted. And it depends on many factors like the bone and tissue phenotype, the genetics, how the anatomy of the patient, thickness of the buccal wall, and the surgical trauma, and the presence of an infection, etc., etc. So what can we do to preserve and to enhance the soft tissue around implant placement? How do we preserve and how do we enhance this phenotype or the soft tissue phenotype and hard tissue phenotype around around our implants? So we can do multiple procedures. We can do it before implant placement or at the time of extraction. We can do it during implant placement, and we can do it after implant placement, or what is called the phenotype modification. So you already have a phenotype and you're modifying that on your existed implants. It's called phenotype modification. So what can we do before implant placement? Again, at the time of extraction in highly aesthetic areas, we can expect significant loss of soft tissue and hard tissue. So tissue grafts will thicken the soft tissue and at the same time compensate for the unavoidable tissue contraction after the extraction. We can use autogenous grafts, whether it's free gingival graft or a connective or subepithelial connective tissue graft. These are harvested from the palate or the tuberosity of the maxilla, and almost these two are the same, except that the free gingival graft contains epithelium in it, and the subepithelial connective tissue graft, we remove the epithelium and we end up with only a connective tissue. We can have some alternative, which is the acellular dermal matrix, and we have, which is an allograft, and also we have some xenogenic extracellular matrix, which is type 1 and type 2 collagen tissues, taken from bovine sources or from porcine sources. So these are, again, taken from articles, and this is where they use a connective tissue graft, and they just place it on the after tooth extraction to enhance the thickness and to compensate for some contraction of the tissue. Of course, the socket was filled with the bone graft, and the tissue graft was sutured in place. This is another method, is to have a free gingival graft placed in the same time after extraction and bone preservation, and they place a free gingival graft and they suture it, and this will again enhance the healing of the soft tissue around these implants. There is alternative solution, which is, again, I talked about. It's called the Micograft seal. I think this is developed by Geislich, and it's I would say I think it's from a bovine source, and it's a collagen matrix. You place it like this, same thing. You put it here, you seal the socket with it, and you close over it with either simple interrupted sutures or crisscross sutures. And they claim that it will enhance the soft tissue healing, the thickness wise, and will compensate for some contraction that will happen. So what is other option that we can do to prevent tissue loss after extraction? So again, as we talked, it's recession and loss of the papilla height and is expected after tooth extraction, and it was shown that more gingival recession will happen in the thin phenotype or biotype compared to the thick biotype, according to Dr. Khan. And so if you're starting with thin gingiva around the teeth, you will end up with more recession after you lose the tooth. So what they suggested, and Dr. Khan is pioneered and individual and teacher and mentor in this field. They started doing an immediate implant placement and doing provisionalization as well. So they place the implant, they place a bone graft to graft the space between the implant and the buccal bone, which is called the gap, and they did a temporary crown or immediate temporary crown. And they noticed that the changes in the gingival margin was not that significant after 12 months. So there was a loss of only 0.3 to 0.5 millimeter of the tissue, which was not significant to the patient. So immediate provisionalization showed a higher volume preservation at the aesthetic concern area, according to Dr. Wang. And immediate placement with immediate provisionalization of dental implants in the aesthetic zone resulted in excellent short-term treatment outcomes in terms of implant survival and minimal changes in the peri-implant soft tissue and also in the hard tissue. And supporting the gingival margin with the provisional crown at the time of tooth extraction and immediate placement preserved 1 millimeter of the facial gingival margin position compared with the non-provisionalized group in another study. So that what they started using. I know Dr. Khan, they started doing this in the late 1990s and starting in the 2000s, and they found a nice results after 12 months. But that after time passes and they monitor the results, they found that more tissue loss happened after 4 years. And some of these patients lost approximately 1 millimeter of their gingiva, or they have a recession of 1 millimeter after 4 years. So they started adding another component, which is adding a connective tissue graft at the time of implant placement. So we started doing implant placement, grafting the gap with bone, and then doing a soft tissue graft or a connective tissue graft, and doing a provisional crown as well. And a recent systematic review found that the combination of immediate loading of the implant and a connective tissue graft allows for a better stability of the gingival margin and thickness of the peri-implant soft tissue. Another randomized study resulted after 2 years showed a soft tissue remodeling of minus 10% in thickness and minus 18% in height in the non-grafted group, whereas in the grafted group, there was a gain of 35% in the thickness. So mainly the thickness was enhanced by this soft tissue graft. And the height was, there was a loss in height, but not to the same degree with using or without using the graft. So the graft helped with the tissue thickness and with the tissue height. So less recession and more thickness happened with using a connective tissue graft at the time of immediate implant placement and provisualization. So now we have this dilemma whether to graft or not to graft. Some people, they defend grafting in each case, and they say that the connective tissue graft in single immediately placed and provisionalized implants leads to less recession of the peri-implant soft tissue at the mid-buccal aspect, irrespective of the gingival biotype, whether it's thick or thin. And some people, they defend using the soft tissue graft only on the aesthetic zone and only when we have a thin gingival phenotype, or biotype. So the decision whether to graft or not to graft is mainly derived by the original phenotype of the patient. Whether if it's thick, then you might not consider the tissue grafting. So here's a case taken from an article done by Dr. Khan. And in this case, Dr. Khan also, I would say, innovated more and pushed the limits even more. So as we can see, the phenotype of the patient is thin phenotype, and this is the CT scan showing how the case started. This is a failing tooth, and we have enough bone in the apical and lingual area for our immediate implant. So he removed the tooth, he placed the implant, and then he grafted the gap. And after that, he made 2 releasing incisions. He preserved the interdental papilla, and he added another component, which is a bone graft on top of the buccal bone, which is called an onlay graft. And then he added a tissue graft, a connective tissue graft, and a membrane. And then he closed the area with sutures, and this is how it looks like. This is how it looks like after 4 months of healing. This is a temporary prosthesis, and we can see after 4 months of healing, we hardly can recognize anything. And this is the case after 3 years after surgery. Again, the aesthetic is preserved, minimal recession, if any, and the case looks perfectly done. And this is the CT scan, and it shows how the buccal bone graft, or the onlay graft that was placed by Dr. Khan, it also enhanced or helped in preserving the soft tissue as a general and the phenotype as a general around this implant. Another option is to, taken from another article, is to remove the implant, remove the tooth, place the implant, and then do a tunnel to rotate a small connective tissue graft from the palate and rotate it and place it on top of the socket and suture it. And this is how it looks like. And we can appreciate the thickness that we gained here in this area. and also the height in this area. So thickness-wise and height-wise, that was very nice. And this one of these advantages, this graft carries its own blood supply with it. Other option is to do your immediate implant placement, and we graft the gap between the implant and the buccal bone, and then we tunnel the tissue graft like this. So they harvested a soft tissue graft, a small soft tissue graft on the palate, and they tunnel it, and they suture it with a small suture like this, and then provisional was placed, and this is the case after 6 months of healing. So there's multiple options and multiple techniques you can use it to preserve this soft tissue phenotype at the time of extraction and implant placement. What about the healed side? If the teeth are already extracted and you want to place your implants, like this case, we can take a look. There is no keratinized tissue, and the mobile mucosa is on top of the ridge where my implants are going to be. There was a previous surgeries done here to do a lateral window sinus augmentation, and then ridge augmentation, and because of flap release and flap pull to cover all these bone grafts, we can see that the advancement of the mesogingival junction to the almost the crest of our ridge. So what can we do? Simply, we can do a split thickness flap like this, and we can harvest the small free gingival graft from the palate, including the epithelium, and we can stabilize in the area. And this is how it looks after 8 weeks. So we can appreciate the thickness wise as a ridge in general because of this soft tissue graft, and also the keratinized tissue width that we gained after this graft. And you can see now the mesogingival junction is all the way in the vestibule, and before that it was on top of our ridge. So from here we move to our implant placement using a guide, and this is how it looks after 1 week of healing. What if the implant is already in place? What can we do? We can do something called Peri-Implant Phenotype modification. And this has been widely and successfully used to convert thin tissue to a thick tissue around dental implants. So they used subepithelial connective tissue grafts, where they found or they were reported to gain 34% tissue thickness after 2 years, compared to sites without grafting, which lost 9.9% of the tissue thickness. And also the thickening of the tissue provides the advantage of decreasing the soft tissue discoloration and show through when a patient has a thin tissue phenotype and the implant or the abutment is visible through the tissue. So again, what we can do, or what can we use in these situations? We can use connective tissue graft or acellular dermal matrix grafts to increase the mucosal thickness around the already placed implants. And we can use also the apically positioned flap with the free gingival graft, again, to increase the thickness and also to enhance the keratinized tissue around our implants. So let's take a look at this example. The implant was already placed on on this area here. And again, as we can see, there is minimal keratinized tissue and around the crest area, and the tissue is very thin, and we have muscle pull, and also around this tooth as well. So we did a small partial thickness flap, and I harvested a free gingival graft from the palate. We fixed it around the area, and I placed my healing abutment on the implant. And this is after 2 weeks of healing, and this is after 8 weeks of healing. And we can appreciate the thickness of the tissue now, and also the width of the keratinized tissue. And here we can go ahead and start fabricating our crown without having to worry about any metal show off, or any problem with the cleaning, or any problem with the gingiva or the tissue around our implant. What if we have already, the crown is already done, as I can see in this, you can see in this example here. This implant have been in function for like 3 years. The patient have difficulty cleaning it. There is bleeding all the time around this implant, but there is minimal bone loss. So what I did again is a partial thickness flap, very small flap, and I took a small graft from the palate. It looks like a tire patch. I placed it there and I fixated it with sutures. And this is how it looks like after 1 week, and then after 3 weeks. And this is how it looks like before and after. Again, we achieved 2 goals. We have enough keratinized tissue now, and the frenum pull is away from the margin here. So the tissue here is stable and firm and easily cleaned and collects less bacteria and plaque. And the other goal is we increase the thickness of the marginal tissue here. And now our abutment does not show off anymore. So now I'm going to be, again, switching gears to a different topic. It's going to be our last topic, and I'm going to go over it briefly. We all know about the guided bone regeneration and the need to do a ridge augmentation for our implants if there is not enough bone to place our implants, and to have a sufficient stability and sufficient thickness of the bone all around our implants. We need to do something called guided bone regeneration or ridge augmentation. And basically, it's use of barrier membrane to direct the growth of a new bone at sites with insufficient volumes or dimensions of bone for proper function, aesthetic, or prosthetic restoration. So what are the principles of guided bone regenerations? First, we have to create a space for this bone to grow and maintain this space. And this space is created by the use of a membrane and also by use of bone graft particles or bone graft material that is a little bit resistant to pressure, and it can keep the space. The second thing is angiogenesis. So we have blood supply. We need this blood supply to come from the original bone and to go over our bone graft or to go over this space and to carry all type of stem cells with it and osteoprogenitor cells that will help us in bone regeneration. And also we have to have a stable area and a stable blood clot, a stable surgical area as a whole. And we all know that if we have a wound or if we have a fractured leg or arm or fractured bone, this bone has to be stable and this wound has to be stable in order to have a good healing. The same concept applies here. We have to have a stability of this area, and we have to have a primary closure, which is tension-free. So we have to approximate our flap without tension, so the flap will cover the whole area without tension. So if we have tension and we have a primary closure, most likely after 2 or 3 days, these flaps are going to become apart and the whole area is going to become compromised. So what are the available things that we have in hands? We have resorbable membranes, non-resorbable membranes. You all know about that. It's either we can have it from porcine or bovine or amnion chorion, which is allograft, or we can have it from cytoplast material that's non-resorbable. It's called a PTFE material or some type of Teflon. And we can have the same material and which is reinforced with some titanium. And we have titanium mesh as well. So these are the membranes that we can use. What about bone graft? Again, many options from autogenous bone grafts, which is or bone graft that is removed in blocks or scraped from the jaw of the bone of the patient. Or we have xenogenic material from porcine or a bovine bone, or we have allografts taken from cadavers, or we have synthetic material or what's called alloplast. So what are the biologics? The biologics are biological products, and these products are fabricated or are being made in a living host, whether it's an egg, whether it's a different animal, whether it's a virus. These biologics are made through genetic process and recombinant therapy process to fabricate these type of materials, which is called the biologics. And these are like the vaccines, the therapeutic proteins, monoclonal antibodies, and etc. One of these biologics that become available in the market recently, it's called the bone morphogenic protein. The BMPs, which are a group of growth factors originally, and it's from the family of transforming growth factor beta, and they were discovered by their ability to induce the formation of bone and cartilage and enhance the healing of fractures and the repair of skeletal tissue as well. So we have a recombinant human BMBs, which are used in orthopedic surgery like spinal fusions or non-union fractures. There is 2 types that have been used, which are the BMB2 and BMB7. And these are the 2 types that approved for from the FDA. The BMB2 in particular causes more overgrowth of bone than any other BMBs. So what is this BMB2? It's a recombinant biologic material. It has 2 critical components, and it's developed by a company called Medtronic, and it's called the Infused bone graft. So it has 2 critical components. One is the recombinant BMB2, and the other one is absorbable collagen sponge. So this is the effective material, and this is used as a carrier because the BMB is liquid. Actually, we cannot put it anywhere. So we have to have a material that is used as a carrier for this to work. And this is how the vial comes in. It comes with a vial of sterile water and the vial of BMB. We mix the BMB with the sterile water, and then this is a sheet of absorbable collagen sponge. We soak the collagen with the mixture of BMB and sterile water, and it's bound chemically to the absorbable collagen sponge after 15 minutes. So we have to leave the sponge soaked with the BMB for 15 minutes before we use it. And it provides 2 to 3 weeks release of the BMB, and which is the 2 to 3 weeks are the critical timing for healing and recruitment of osteogenic cells. So because it bonds to the absorbable collagen, it slowly released to the area and it rapidly cleared from the system. So there is minimal systematic exposure. At 22 days, the BMB2 is almost gone at the site. So it works for almost 3 weeks, 22 days, which again, it's the critical time for the starting of the healing process and the recruitment of all the cells that we need for for the bone formation. How does it work? This is the mechanism of action. First, we have to implant it in the site, and then chemotaxis happen and proliferation of the stem cells in the area, and then differentiation of these cells into osteoblast, and after that the osteoblasts start forming bone, and angiogenesis happened between the bone island as well, and then a period of remodeling happened after that. So the goal is to regenerate pure native bone, which is called a true osteoinduction, that this material provides. It's a stimulation of osteoprogenitor cells to differentiate into osteoblast and then begins formation in new bone. This is a histology taken from one of the articles that supports the use of BMB, and we can see it's native island of native bone that is happening. And this is de novo bone formation. So there is no bone grafts, there is no particles, there was nothing in the area except for a sponge soaked with this BMB material. So again, BMB was approved in 2007 by FDA for the use in sinus floor augmentation and for extraction socket preservation. And until now, these are the only two procedures that are FDA approved for the use of BMB2. But a lot of people are using the BMB off-label. So they use it for other procedures, but under the radar. Reports have shown that the use of this material in the sinus gives comparable results as using autogenous bone, which is the gold standard bone. Dr. Herford and Boyd in Loma Linda University reported the use of this material in the mandibular defects where they have a mandibular discontinuity. And these defects have been successfully treated by the use of this material without any type of bone graft. So it's only this material held up by some type of mesh. Again, other studies show that BMP2 has been successfully used in complex treatment of the face, also in congenital jaw defects, the alveolar atrophy, and maxillary fissures as well. And lately, favorable clinical outcomes in the peri-implant bone resorption also has been reported. So what are the disadvantages? Is the handling properties. This material has to stay stored in a very special area and under a very special temperature, and has to be handled very carefully. But again, it's once you follow the instructions, you have no problem handling it. And as you use it one time after one time, it becomes easier to use. The other major problem, which is the cost. I think one vial of this material is over $1,000. So I think this is very expensive compared to other bone grafting material. But it's a promising technology, especially in the use of oral maxillofacial surgery and implant dentistry fields. So let's take a look at some of the cases. This case is courtesy of Dr. Daniel Konihira, which is a faculty in the Department of Periodontics in Loma Linda University. He's a nice gentleman and excellent clinician, and he was kind enough to share this with me. And he's truly the only one who uses the PMP in the perio department right now. He's specialized in this type of grafting. So with the BMP, we always have to use some type of rigid fixation, like titanium mesh. We cannot use, or it's very hard to use it with a resorbable membrane because the membrane is going to collapse. So this material is soft. It's collagen. It's basically like a collagen block filled or soaked with the BMP material. So we need some type of support to preserve the space for this material. And we have to use this titanium mesh. So this is how he placed the two titanium mesh, and we can appreciate here that we start with the narrow ridge, especially on the lingual side here, where we have to place our implant a little bit lingually in the anterior zone. So we'll have a thick buccal bone, and the implant screw hole will come from the cingulum of the tooth. So he placed the collagen under the mesh, and he stabilized the mesh and achieve a primary closure. This is how the CT scan looks like after, I would say, 4 to 6 months. And this is how the bone or the mesh looks like after around 6 months. He opened on it, and this is when he removed the mesh. There is bone everywhere. So this area was filled with collagen, and now it's bone. There is no bone graft, nothing. So this is de novo bone formation. There is a soft tissue layer of pseudoperiosteum. You can leave it here, no problem at all. It's filled with blood supply, and you can do your implant osteotomy through that, and you can appreciate the thickness that we gained. And that's pretty much it. This is another case, again, done by Dr. Konihira. We're starting with a very thin ridge. This is how we ended up. Very nice and thick ridge with no use of any particulate bone graft or any block bone graft or anything. It's just a metal mesh and a BMP sponges and a good primary closure. And this is how it looks like after 2 implant placement, and the patient is going to have a fixed partial denture fabricated. This is a case that was done in, again, there was number 15 and 14 implants. Number 15 implant failed and it was removed in 2018, and then number 14 also failed, but they tried to salvage it, so they removed the crown and they tried to salvage number 14 with the bone graft. So they did a bone graft and they did a sinus graft on number 15 area here, as we can see, but the bone graft did not take, and we can see that the bone graft is particles is away from the native bone and it didn't work, and we still have this amount of bone loss and the implant is moving basically. So what I did is we decided that the implant need to be removed, and this is how we open the flap, and we can see the implant exposure that we have. It's a short implant already, and with this amount of exposure there's no way that we can salvage it. So we decided to remove the implant, which were loose anyway, and we ended up with a huge vertical problem or vertical deficiency here. We decided to use the BMB in this case, and the reason is the need for a vertical graft or vertical enhancement, and the other reason is the multiple surgeries that the patient had, and we want to have something that really works and something that compensate the local factors that the patient have over multiple failures that happen in that area. So I placed the titanium mesh, and we placed the collagen soaked with the BMB below it. This is how it looks like, and then we close with a primary closure. This is how the area looks like after 2 weeks, and this is after 2 months. And this is a PA radiograph after 5 months of healing, and we can appreciate that there is bone growing everywhere vertically. Some of the material seeped, looks like, beneath or on top of my mesh, and there is some bone even forming in the soft tissue in the flap, which is very interesting. So I am gonna open on this case in a couple of months, and I'll see how it's gonna turn. So the reason why I brought the BMB in this lecture is just an eye-opener of the newer materials that we have right now. Maybe in the future, the bone grafting as we know it is going to change and shift into more biologics. We already have other biologics like the GEM21, which is, I think, a platelet-derived growth factor. So these type of growth factors and growth enhancers are getting more popularity right now. And we have very nice results that are documented with the use of these materials. But the problem, again, with this technology is the cost. It's a lot, but maybe in the future it'll be more affordable. And with that, I would like to conclude my presentation. Thank you, everybody, very much for listening. And I know keeping an attention and keep focusing in this world that we live in right now is very hard. So I wish that I presented something interesting for you, and it's just an eye-opener on what's happening in the implant dentistry field, and I hope that you all benefit from this. If you have any questions, you can reach me through Facebook or Instagram, and I'm looking forward to meet a lot of you and to hear the other lectures that will be presented during this convention. So thank you, everybody, and thank you, Dr. Mazen, again, and have a great day.